Thank you, Steve. Good morning, everyone, and thank you for joining us for our journal club today. Let me see here. So we're going to be talking about patterns of anticoagulation used in patients with cancer, with atrial fibrillation, and/or Flutter. This was published a few months ago in the Journal of American College of Cardiology, Cardio-Oncology. All right, and Mike Fradley is our lead author. I have no disclosures today. Give you a little bit of a background. Patients with cancer are obviously at increased risk of various cardiovascular complications, including AFib. The prevalence of this in this population anywhere between 2 and 15%, although this may be an underrepresentation due to screening measures. There are certain classes of antineoplastic drugs like tyrosine kinase inhibitors that have higher prevalence of AFib, as you might know. And of course, stroke is one of the most serious side effects or adverse consequences of AFib and Flutter. The rate of stroke in patients with cancer could be higher than the general population, and both cancer and AFib are independent risk factors for ischemic stroke. That's why anticoagulation is really our mainstay of therapy, and the goal here is to decrease the risk of devastating thromboembolic events. Patients with cancer, in particular those who undergo active chemotherapy and those who are survivors, are not really well represented in clinical trials. So it makes their management and choice of anticoagulation for these patients a little challenging. And we know from registries that only about 85% of patients with non-valvular AFib in the general population get a prescription for AC. We don't really know that percentage in the cancer population. So our aim for the study was to
Mo, you good? You're muted.
Can you hear me okay?
Yeah, now you're back. Okay, sorry about that.
That's all right. Alrighty. So this is how we went about the study. Full disclosure, I only came aboard after the data were collected, so I still took some of the credit, but the hard work was already done. But between January and December of 2016, patients who had an EKG at Moffitt Cancer Center, either in inpatient or outpatient setting, were identified. And from this sample, we looked at both patients who had AFib and Flutter and cancer diagnosis. So if they have cancer and a documented episode of AFib by EKG, those were included. Our electrophysiologist looked at every EKG and confirmed that it is actually atrial fibrillation and/or Flutter. And the medical records of these patients who met the inclusion criteria, which, as we said, cancer diagnosis and at least one EKG showing AFib and Flutter, were comprehensively reviewed. We looked at the baseline characteristics of these patients to calculate their CHA2DS2-VASc and HAS-BLOOD scores, and other variables like hemoglobin, platelet counts, history of venous thromboembolism, Karnofsky scale, and LVEF by echo, as well as cancer type. The occurrence of perioperative AFib, chemotherapy exposure within 3 months of the arrhythmia diagnosis on the EKG, and active chemotherapy at the time of the incidence were also collected. And an increased risk of stroke was defined as CHA2DS2-VASc of 2. Again, this was collected in 2016, so the update to the AFib guidelines had not been published yet. So at the time, any CHA2DS2-VASc score of 2, regardless of gender, was considered a high risk of stroke, plus an increased bleeding risk of HAS-BLOOD score 3 or more. All right, so our results showed about 9,800 patients had at least an EKG at the cancer center here, either inpatient or outpatient. And of those, 472 patients, about 5% of everybody who got an EKG, had both cancer and AFib or Flutter and EKG. And it kind of goes along with some of the registries of the incidence of AFib in this patient group. The mean age of this cohort was 73 years. Remember, this 472 will constitute our cohort for the study. The mean CHA2DS2-VASc score was 2.8. Among this group, about 213 patients, about 45% of patients, were given anticoagulation, and 54, almost 55% were not. Now remember, this is the cohort of patients who had a elevated CHA2DS2-VASc score. Patients who were given anticoagulation were older, on average 76 years, and had more hypertension. Patients with histories of AFib, so that EKG was not the first episode of AFib, and those with a CHA2DS2-VASc score of 2 were also more likely to be prescribed anticoagulation. This is table 1, and this is again of all of the patients in the cohort. So I highlighted the ones, the fields that reached statistical significance here. So you can see the age group, older patients were more likely to be given prescription for anticoagulation. Hypertension, the presence of heart failure, prior AFib, prior stroke, prior major bleed was a major factor in not giving anticoagulation to these patients. Current chemotherapy use, preoperative AFib diagnosis was less likely to be associated with giving AC prescription. Obviously, platelet count less than 50,000 were less likely to leave the hospital with a prescription. And when we looked at the cancer types, hematology cancers patients were less likely to get a prescription. Cutaneous cancers were more likely to get a prescription. CHA2DS2-VASc score of 2.4 and up to, and has blood score of more than 3 was less likely to get a prescription for AC. So just to talk briefly about what we just saw, patients with active chemotherapy at the time of documented AFib and Flutter were less likely to get a prescription, 38 versus 58%, almost half, as well as those with elevated Has blood score. Patients with hematology malignancy were less likely to be given AC as opposed to the cutaneous malignancies, like we said. There were really no differences in other cancer types in terms of who gets a AC prescription. Among those with active chemotherapy or those who were treated in the preceding 3 months, only 36.5 patients were given AC. And we'll talk about why we think that happened. Only about 38% got warfarin, about 54% got DOACs, and of those who got direct anticoagulant agents, 47% were given rivaroxaban, 42% were given apixaban, 9% were given dabigatran, and 2% were given edoxaban. Now, when we looked at a group of patients who we thought were appropriate candidate for AC, those who were had a CHA2DS2-VASc of 2 and a Has blood of less than 3, those were about 63% of patients, so 296 patients of the whole cohort. Among those, only about 54% got prescription, so 44% of those patients who were appropriate did not get a prescription for AC. And we tried to compare those who had AC with those who weren't based on these CHA2DS2-VASc score. We'll show you this more in table 2, but basically almost 49% of women did not get that prescription and 51% of men. Baseline hypertension was more prevalent in those who got the AC prescription. Again, we're talking now about the appropriate candidates for AC. Only 18% of those who were not given AC had a thrombocytopenia with a platelet level of less than 50,000. The patient characteristic for those 296 patients were similar to the majority of the group. So this is table 2, which is those who were appropriate to get an AC prescription. So those again with the CHAS-VASc score of 2 or more and a Has-Blood score of less than 3. And again, you see here, again, age was a driving factor to get an AC. So older patients, fortunately, got their AC prescription. Being a female basically meant you would not get a prescription even if you are a candidate for it. Presence of hypertension was more likely to get a prescription. Prior AFib as well. Prior major bleed, obviously, those did not get a prescription. Current chemotherapy users did not get the prescription. Having preoperative AFib did not get a prescription for AC. Platelet of less than 50,000 did not get a prescription. And again, we see the same thing here. Hematology cancer patients did not get a prescription. Cutaneous patients did. So to summarize, among those who were appropriate candidates for AC, you're more likely to get an AC for older versus younger if you had hypertension and a prior AFib versus having a first documented episode. Prior major bleed, you're less likely to get an AC, so as a current chemotherapy use. If you had perioperative AFib, you are less likely to get AC as opposed to a non-operative setting. Platelets of less than 50 did not get AC as opposed to those who had platelets above 50. Cutaneous malignancy patients who had basically more likely to get AC compared to the hematology patients. So if you are a younger woman with hematology malignancy, good luck getting an AC prescription. All right, so we looked at odd ratios, so older age, hypertension, prior stroke, as we said, and history of venous thromboembolism were more likely to get a prescription. On the opposite side, the current chemotherapy administration, thrombocytopenia, history of major bleed, and presence of perioperative AFib were all inversely related. And you can see the odds ratio here. This is odds ratio basically for those who did and did not, and you can see I highlighted most of this. Basically, age above 65, you probably are more likely to get a prescription, but it's stronger if you are above 75. Hypertension, prior AFib, prior stroke, renal disease was in the whole cohort. If you had advanced renal disease, the odds ratio of getting AC was 0.24. You can see the prior major bleed, prior venous thromboembolic events, chemotherapy use, current or prior, and preoperative AFib. Using NSAIDs was also less likely, was an inversely related event there, and the platelet counts of less than 50,000. Brain mets weren't that common in the cohort, but patients who had brain mets were less likely to get a prescription. So to summarize this, we had 472 patients with cancer and AFib or Flutter. 296 of those were at a higher stroke risk by the CHAS-VASc score of 2 or more, and a low bleeding risk by Has-Blood score of less than 3. 44% of those did not get a prescription. Those who were older with hypertension, prior stroke, and venous thromboembolism were more likely to get anticoagulation prescription. Those with current chemotherapy, prior bleeding, renal disease, and thrombocytopenia were less likely to get a prescription. factors that we thought contributed to those decisions of given or not given a prescription were a higher CHA2DS2-VASc score, more than a year of overall survival, mechanical heart valves, intracardiac thrombus, and venous thromboembolism were probably factors that favored anticoagulation. And those that oppose it were high blood score of 3 or more, thrombocytopenia, coagulopathy, history of major bleed, drug-drug interactions, especially with the ibrutinib, and brain metastases. So we know the suboptimal use of AC in these patients can lead to dramatic and significant health and economic consequences. We know from prior studies that patients with AFib, on average, if they have cancer, they're less likely to get a prescription for anticoagulation than those who do not have cancer, regardless of cancer type. And interestingly, if you send those patients to a cardiologist, they probably have a better luck, leaving the office with a prescription for anticoagulation without increased risk of bleeding. That was a nice paper in JACC a couple of years ago. Okay. Now, what do we do with these patients with elevated CHA2DS2-VASc score and not? We've been basing our risk assessment for stroke and has blood and bleeding risk on the CHA2DS2-VASc score, basically, which was derived from a general population. But there are some data that suggests that the CHA2DS2 score may be more appropriate for patients with cancer as opposed to CHA2DS2-VASc. We know those patients basically don't get well represented in these trials. And also, these scores don't take into account the presence of malignancy or life expectancy. So we're not sure what to do. When I see a patient with AFib and a CHA2DS2-VASc score of 1, let's say a male with a CHA2DS2 score of 1, do you deem them a low risk for CHA2DS2-VASc for a stroke and give them aspirin, or do you think they have cancer and they're typically at a higher risk of thromboembolic event, and you give them an anticoagulant? I don't know. I look forward to the discussion and what the group thinks. Same goes for the HAS blood score here, which is hypertension, abnormal liver and renal function, stroke, bleeding, labile, international normalized ratio, INR, old age, and drug or alcohol use. We know that its use in patients with cancer has been questioned, and we know that our cancer patients have higher bleeding for tendencies, and especially those with gastrointestinal cancers. One study suggested that cancer itself was a stronger predictor for bleeding than other risk factors, especially if you add it to the HAS blood score, led to defining higher bleeding risk patients. The other thing that we noticed here was that the fact that some patients with prior major bleeding did not get an AC prescription. Now, a lot of these events were reversible. Let's say you had a bleeder in the GI tract and that was cauterized. Should that be a reason for people not to get AC as long as they're alive? We don't know. We don't know, and we're not sure if that's a correct approach, if there was a reversible cause. And we still don't know what really the safest platelet count is. And I'm not sure where the 50,000 came from, but we all seem to agree on that number. And practically anything below that, we basically don't give anyone an AC regimen. We know from a lot of the DOACs trial, platelet count of less than 100 were excluded. So it really leaves you in the dark. And I don't think we have any prospective data comparing those DOACs in this particular subset of patients. In our study, only about 19% of patients who did not get a prescription for AC had a platelet count of less than 50,000. So I think it goes beyond the thrombocytopenia here. There's something else preventing our colleagues from giving prescriptions for AC to these patients, and it's not just the low platelets. And you've seen here that the majority of our patients got DOACs, and the safety of those agents really were all coming from post-hoc analyses. I don't know of any head-to-head trials of DOACs in this patient subset, but from what we've been doing so far, they seem to have a reasonable safety profile. Data from the Aristotle, which was the apixaban versus warfarin trial, showed that the safety was preserved basically with apixaban versus warfarin in those with and without cancer and AFib. Engage-TIMI, that was the idoxaban trial, basically showed us that active malignancy and high rates of death, major bleeding in cancer patients compared to those without cancer, which makes sense. But it seems like the safety profile of idoxaban, at least in the post-hoc analyses, were preserved when you compare it to warfarin. Data from the Rocket AFib, which is rivaroxaban, and Relay, which is the dabigatran, showed us that actually the bleeding risk is higher in patients with cancer. It's about 2 to 6 times higher than those without cancer. So I don't know what the group has been using. I've been using a lot of apixaban recently, but again, there's really no excellent data to support this practice. And what about the active chemotherapy and not getting an AC prescription? We really don't have a good answer, but we have some theories here. Something that's unproven is that if our oncology colleagues think that the presence of AFib during the time that you're getting active chemotherapy is a temporary thing, and therefore, if you don't anticoagulate for that period of time, patients may not be at harm. Just throwing it out there. But the more, I think, reasonable thought is that, well, if they get active chemotherapy, maybe they have coagulation imbalance, maybe they have higher INR, maybe they have low platelets. That could increase the concern for bleeding complications. Not sure. We know on the other side is that having active cancer itself and active chemotherapy can put people at a higher risk of thromboembolic events due to endothelial injury, especially with some certain chemotherapy agents. So I don't know about withholding anticoagulation in this population. It should probably be, like in most cases, on a case-by-case basis. There were some limitations to our study here. This was a retrospective analysis with all of the limitations that comes with. Our study wasn't powered to detect any meaningful difference in the thromboembolic events in those patients who did not get the anticoagulation. And we really don't know the true incidence of AFib. It's probably higher than we've detected. We know from registries in the general population that if you increase your detection time by wearing monitors for longer or having patients come to the office longer, you're probably more likely to find AFib. But we couldn't tell you this from our study. But again, you saw the incidence of AFib was there by 5% in this patient population. Both the CHA2DS2-VASc score and the Hasblat scores both of them have limitations in this population. But again, until something better comes along, I think we're probably going to keep using those. And again, I mentioned this earlier when we looked at the data that was in 2016, and at the time, the AFib guidelines did not really discriminate the score based on gender. So that's why we gave everybody a score of 2 and a high risk score. We don't know if we might have over or underestimated that risk for female patients. And, I don't know if that's the reason why patients weren't, especially female patients who weren't getting AC prescription. Perhaps their CHADS VASc score were lower than the recommended cutoffs later on. And we only looked at 9 cancer types, but we thought those basically considered the majority of cancer patients that we see here in our cancer center here. So I don't know if we can draw conclusions about other subgroups of cancer patients. So we concluded that almost half of cancer patients with AFib who were eligible to get anticoagulation did not get a prescription for anticoagulation. We concluded that current chemotherapy patients significantly reduce the likelihood of getting an AC. So, watch for those patients who are on active chemotherapy, and I would make sure they have a prescription if there are no other contraindications. And this should raise the awareness of the consequences of this devastating disease. Going forward, we really need to have better ways to assess the thromboembolic risks of AFib in this population. I've been trying to find a way to squeeze in the cancer into the CHADS VASc score and see if that gives us any better discrimination in terms of stroke risk in this cancer community, but haven't had the chance to do that yet. But we should have probably a better way to determine this risk. And we really don't know the true thromboembolic risk potential for AFib in the cancer population. We should look into that. If you have any questions, please feel free to email me and shoot me a message on Twitter, and I'll open the floor for questions and comments. Thank you.
Hello, may I?
Hello.
Good afternoon. This is Agnes, Bari, Italy. First of all, congratulations for this amazing presentation and for choosing a challenging issue, because we know that DOACs are anticoagulants indicated in venous thromboembolism in cancer patients. But in the other clinical setting, in atrial fibrillation, we don't have specific trials, but ad hoc in this population. However, recently was published a statement of ERA, so the European Society of Cardiology, and in cancer patients, they now indicate as a first choice of anticoagulant therapy DOACs, second choice low molecular weight heparin, and then warfarin. And about thrombocytopenia, there is a statement from ISTH, International Society of Thrombosis and Hemostasis. If the platelet count is over 50,000, we can use a normal dose of, for instance, low molecular weight heparin. If it is between 25 and 50,000, half dose. If it is under 25,000, there is an absolute contraindication to any anticoagulant therapy. So thank you very much.
Thank you very much, and I appreciate your input there. And this is great to know there are statements on this. The DOACs use, I'm still unsure of the consensus document, basically relied on prospective data. From what I understand, most of what we have is post-hoc analyses when it came to DOACs. I don't know, maybe if anybody else knows and enlighten me, that would be great. But I think most of the data we have are from post-hoc analyses. It's obviously always great to have any guidance. Any guidance is better than none. So thank you for that input.
Looks like Vijay Rao had a question. Vijay, you want to jump in?
Yeah, no, excellent presentation, Dr. Alamar. Really enjoyed that. Just a question about the percentage of patients with AFib flutter who actually had cardiology weighing in on anticoagulation. I think as we start thinking about practices across the world in terms of the communication between the oncologist and the cardiologist. I know in your study, these were EKGs that were done at your institution, and I don't know if you had any data or any information about how often a cardiologist weighed in on that, and if in fact that impacted the anticoagulation choice, whether the patient was actually prescribed an anticoagulant, if there was a discussion between the two groups.
Thank you, Dr. Rao. Excellent question. Yes, we did not look into this. I can tell you from experience that we don't see the majority of those patients here, especially if our referral center here. A lot of our patients have outside PCPs and usually end up managing those. I don't have that piece of information for you, but I think, if, like you said, if we end up sending these patients to cardiologists, I anticipate the prescription for AC will probably be higher. I know I'll probably take a look back and see how many of those we saw, but that's an excellent point.
Hey Mo, it's Isaac Ray. How you doing?
Very well. Hi, thank you.
Yeah. Working on this project, there's a piece of information I forgot to get, and maybe you're aware of it. Do we know how many of these patients had strokes? At least after they went to Moffitt.
Yeah, no, thank you, Isaac. We do not. Yeah, we do not. We thought the constraints and the time limits, we didn't get to collect the data of stroke incidents after that. That would have been very helpful.
Yeah.
That would have been a really good thing.
Yeah, that's okay. I know we weren't powered for it to begin with, but
yes, you guys probably did the hard work. Yeah, I just did. Just put my name on it.
So, hey, Mo, this is Jose from St. Louis. How are you?
I'm good, good.
So, good. So one of the questions that I had was the use of anticoagulation in your experience and ibrutinib. From a practical standpoint, I know there's always been a concern about the combination of those two, but have you really seen an increased risk of bleeding in patients who are on ibrutinib and a direct oral anticoagulant at Moffitt?
Yeah, an excellent point. And we didn't have a lot of ibrutinib patients in this cohort to draw any major conclusions. My short experience, no. I think the only trouble we've seen was basically those who were on triple therapy for PCI and AC and ibrutinib. But AC itself, especially in those with lower Has blood score, I haven't seen any meaningful or major bleeding event. We know from prior studies and documents like DOACs are usually safer in this population. I would be worried about Coumadin for those guys. But I think going with the DOACs, especially if you adjust it well for creatinine clearance, and if you make sure there is no other ibrutinib drug interaction with anything else like a GP3 inhibitors that would increase ibrutinib concentration, you're probably okay. Again, I'm not aware of any solid data to suggest safety profile.
Good. And then the other point that I was going to ask you about is that, it sounds like there are two major factors to consider. One, like you mentioned, the type of malignancy. Is it a solid organ, is a solid tumor malignancy or a hematologic malignancy? But then the other point is, at what point during cancer treatment is anticoagulation being considered? So in patients without a hematologic malignancy who would qualify for prophylactic anticoagulation based on their corona score, and would you feel more comfortable in transitioning those patients to full anticoagulation if they were to develop atrial fibrillation and have a platelet count greater than 50,000, but still be getting chemotherapy or in general have a higher risk of bleeding?
Yeah, excellent point. Absolutely. Yes, I think, and again, it has to be case by case, but once they get off that 50,000 threshold, typically start them on AC, even if they have an active hematologic disease and active therapy. Again, I think it's always going to be a frank discussion with patients. Like, listen, if anybody's going to be at a higher risk of a bleed, probably be this patient, but again, the stroke risk is not low. And I see them soon, I see them often. I, call them. I have the office call every now and then, make sure they're not having a bleed. It's not a, here's prescription and, go into the wild. You give them the prescription and you just, keep them close. And you just have that full disclosure that the bleeding risk is real, but the stroke risk is probably higher. So yeah, once I think once they get off that 50,000 threshold in terms of platelet counts, I typically start them on AC. They have a high CHA2DS2-VASc score, Corona score.
Dr.
Hey,
Alamar,
great job.
sorry, just one last quick question. Do you have any thoughts about the Watchman device? I mean, particularly if individuals with malignancy have a prognosis that say is fairly good, that you think might live longer than a year, for example, would you see any role for Watchman device implementation in some of these patients with AFib or Flutter to minimize the amount of anticoagulation they might need?
Excellent point. Excellent point. And our group is actually, I think, is a little bit more aggressive than what I've seen so far in terms of offering Watchmans and, in fact, other interventional procedures to these patients if they have a reasonable prognosis. Yes, I'll probably do it more often for the hematology patients, especially like if you have an MDS patient, basically, who you'll know their platelet trajectory is going to drop to below 50 over the next few months. It's really, you have to have a good relationship with your oncologist friends here. And if you're at, an example here is, those typical MDS patients who have a platelet count hovering in 70,000 and also have AFib. But if you know from their oncologist that their platelets count is going to be in the 30s, 40 for months to come, based on their disease progression, it might be a better window to grab that patient, offer them a Watchman, and once they hit that below 50,000 threshold, at least they'll have something. Again, we really need to have some urgency. We actually started. It's interesting that you mentioned that with our interventionals group here to kind of look into our basically hematology patients group here and look into these patterns of Watchmans and see how successful can this be and how safely can this be done from a procedural perspective, and long term of how effective that can be in decreasing stroke and bleeding risk. Excellent point. I think we definitely need to look into this, and I'll be happy to work with anyone out there who's interested in doing this. But this has been my approach. If I anticipate they're not going to be an excellent AC candidates, I'd offer them a Watchman eval. Their prognosis is reasonable. And what's important here is that it's not like one of those things where patients will feel immediately better getting the Watchman. It's different than if you have a patient who's expected prognosis a year and have severe AS and is out of breath around the house. Obviously, you'll fix their aortic stenosis and give them a TAVR to improve their quality of life first. For the Watchmans, it's not an immediate thing that they'll notice, so you'll have to sell them on it. Most people will be happy not to take the anticoagulation after the Watchman, although it's not really the recommendation. I know that they have to still take it for 45 days after the device, and after that, even if they have a reasonable bleeding risk, you should still probably be on it, especially those with a high CHA2DS2-VASc score. But excellent point, and I think Watchman definitely should have a role in those patients.
Dr. Alamar, I think Sebastian Smith from Poland had a question or a comment?
Sure. Hi, Sebastian.
Thank you. Can you hear me?
Yes.
Hello, Mohammed. Congratulations for your excellent presentation. I like your data, but I think that your main results are very sad for cardio-oncologists because cancer patients during active chemotherapy are not good candidates for anticoagulation. I can understand when we can afraid about low platelet count during chemotherapy, about the risk of renal dysfunction, liver dysfunction, and of course drug-drug interaction. But when we decide that the risk of stroke is high, we should decide about thromboprophylaxis, antithrombotic prophylaxis. And my feeling is that we should know about real risk and real data of stroke in such population, in cancer patients. Maybe you know such data about the real frequency of cancer patient during active chemotherapy. How many patients, how often they can expect stroke, can experience stroke during active chemotherapy?
Yeah, thank you for the comment. Excellent point. And we still haven't found a solid reason why those patients don't get a prescription for AC. You're absolutely right. The thromboembolic risk is significant in those with active chemotherapy. Sometimes I try to put myself in the oncologist's shoes and think, what this, why these patients didn't get a prescription. And sometimes, and then again, no data is all anecdotal. There's a thought out there that an episode of AFib during an active chemotherapy might maybe a transient one. Again, there's no really proof of this. We know that if you continue to monitor these patients, in general population at least, you'll probably detect more AFib than what we've reported today. But also, those patients end up going for a biopsy here and a procedure there. And I think the fact that these patients need to interrupt their AC every now and then for this procedure during the active chemotherapy would be a reason for them not to get a prescription. I think to go over this, you need a lot of education and a lot of assurance that yes, the risk is there, but the stroke risk is real, and we should probably go ahead and give these patients their AC prescription. The good thing about those patients with active chemotherapy is that they're back in the hospital every couple of weeks. So it's not like they go in, they never see them for 6 months. They'll be coming to the office a lot, so you'll be able to evaluate the bleeding risk for those patients quite often. I think that should be encouraging to a lot of folks to give their patients their AC. But I agree. I think we need the dedicated research into those who get active chemotherapy and follow them over months and see what the incidence of stroke is. And those who my suspicion and hunch is it's going to be a significant number. Thank you for the comment, though.
And Dr. Fradley is with us. Glad to have him with us. Mike, if you want to jump in, and you're one of the principal authors here, so maybe you have some comments or questions.
Thanks, Mo. That was a great presentation, and I think it was a perfect summary of the findings. I think the one thing I wanted to say, and I think this really kind of underscores some of the comments that were made previously by Sebastian and Jose and Vijay, is that one of the deficiencies currently, at least from my perspective, in cardio-oncology really has to do with the risk score and whether or not the CHADS-VASc or the CHAD score is actually the right risk score that we should be utilizing to determine whether a patient would benefit from being on an anticoagulant. And there is some reasonable data and several good studies out there that have suggested that the CHADS-VASc score doesn't really apply in a equivalent fashion in the cancer patient population. So I think that these data really can serve as, you know, a foundation along with some of these other studies to really begin the process of figuring out who is really the high-risk population that would most benefit from anticoagulants, particularly during and then after they complete their treatment and move into sort of a survivorship territory.
Absolutely, I 100% agree. We're all going by what we know best, and which is was done in cohorts that were absolutely not representative of the complexity of the patients that we deal with. The other thing I want to add is I think we should, and probably the cardiologists on the group will probably agree with this, we should start seeing these patients in our clinics. I think that's probably, I can think of the best way of getting these patients on AC is to get them into a cardio-oncology clinic. Someone who understands their stroke risk, says their bleeding risk, and we should really just start seeing these patients. They come here close, and they have come here too often, and you know our clinics are next to the oncologist clinic, so just it's a one-stop shop. See them and start them on AC. I think that's probably you know the most practical thing I can think of going forward for those patients.
And one of the more specific examples, at least in our experience or in my experience, has been the patients, for example, with AL amyloidosis or amyloidosis, where the CHA2DS2-VASc score, we rarely take it into, I rarely take it into account because we've seen patients in their 50s with no other comorbidities who have AL amyloidosis and have stroke, for example, with or without AFib, and then they have AFib. And the bottom line is that me and some of my colleagues, we have a very low threshold to empirically start full anticoagulation in AL amyloidosis until they get started on chemotherapy. And because, for example, just as it has been published before, even on anticoagulation, those patients still have for stroke, they still have evidence of intracardiac thrombus, and it takes a combination of both anticoagulation and chemotherapy for them to reach to a point where, for example, it would be safe to consider doing cardioversion or see resolution of the intracardiac thrombus. So that would be one example where, we have to definitely take into account the type of cancer or malignancy and how it behaves, and that's regardless of the CHA2DS2-VASc score.
You're absolutely correct. Yes, so the patients with cardiac amyloid especially can develop LA thrombi even in sinus. So to just say your CHA2DS2-VASc is 0, go home on aspirin is just absolutely, I don't think would be reasonable. And again, I'll have this discussion with a lot of patients, so I see it. A man with a CHA2DS2-VASc of 1 or a woman with a CHA2DS2-VASc of 2, and obviously, and it's, I understand that patients are concerned of taking a heavy-duty blood thinner, but a male with a CHA2DS2-VASc of 1 and cancer, I think, is not a low-risk patient. I try to lean on the side of let's start AC and let's just keep you close, and bleeding happens and we'll stop and reevaluate. But I agree with you. Every cancer patient is different. Every patient is different, and has to be tailored to their needs.
Mohammed, this is Vijay again. One other thought as a corollary is we have so many patients now with AFib, chronic AFib, who are on anticoagulants, who then develop cancer, right? Which is sort of the opposite of what we were just discussing, potentially. And then say they get chemotherapy that drops their platelet counts. And so we sort of have that situation that comes up not infrequently. And the consideration is, do you stop anticoagulation if their platelet count's less than 50,000, if they've got a CHA2DS2-VASc of 8, for example, have had a stroke, high risk of thrombosis or stroke, and yet now you have low platelet counts? What do you do? What do you recommend in that sort of setting?
Yeah. No, you're absolutely right. So there are some actual data just that being on AC led to more GI cancer detection, for example. Look at those who come in bleeding after they start the AC with AFib, and there was a thought that the same could happen with urological malignancies too. This one, it's a tough one. You know, obviously, if I think their bleeding risk is, you know, let's say, you know, it's a GI cancer, they go out, they have it resected, and they come back, and it's, you know, the source of their bleed is you know, managed. And obviously, that's a no-brainer. You put them back on blood thinners. But I think those who I can't really anticoagulate, I'll offer them Watchman. I think that's the best I can offer them right now. You know, someone with a CHA2DS2-VASc of 8 is just a stroke waiting to happen. You know, you'll have obviously difficulty keeping those patients on even maybe 45 days of anticoagulation. So I know they have, there are, you know, interventionalists who've been trying the dual antiplatelet therapy for those patients as opposed to AC. But again, I don't think there's any excellent data here. It's a gray zone. But my approach to this is that if I think the bleeding cause is a reversible one, just have them go through what they need to do to treat that bleeding cause and put them back on AC. If it's not something that's going to be resected or managed in the short term, I'd offer them a Watchman and just you know, keep fingers closed, you know, crossed.
And Eric Harrison, Dr. Eric Harrison has a comment or question. Go ahead, Eric. We can't hear you. Must be a problem with his microphone.
So Dr. Harrison is a neighbor anyway, so we can stop by and chat.
Right. And Dr. Ismail Khan says she's not near a microphone, but her question was, do you think it's because many of our drugs have inherent anticoagulative properties? How does that relate?
Yeah. Hi, Rohi. Good morning. You know, I don't think, you know, at least on the cardiology side, you know, I still, you know, every time I see a new chemotherapy drug, I look it up and look at its safety and adverse event profile. I don't think we have that many that should be concerning to our oncology colleagues in terms of bleeding risk. I know ibrutinib is a special one, obviously, but you know, unless we're using Coumadin for those patients, you know, which we're not, the safety profile of DOACs seem to be okay. And again, you know, probably this is like the theme of the day is we need better data to prospectively look into these patients and follow them over a period of months and see their true, you know, ischemic and thromboembolic and bleeding profiles. Obviously, oncologists are on average smarter than me in this hospital, so they probably would know more about the inherent bleeding properties of their chemotherapy agents. I don't think I've seen something that would stop me from putting someone on full AC, unless it was maybe ibrutinib, acalabrutinib on someone with triple therapy, in which case, you know, probably in most triple therapy patients anyway, you know, that's just a, you know, disaster waiting to happen. I'll stop one of the antiplatelets and just put them on an AC as soon as I can, after talking to their interventional cardiologist, for example.
Hello, Dr. Alamar. I changed mics. Can you hear me now?
Yes.
This is Eric Harrison. We have a group that would be an appropriate control group for you. We have a group of patients that were having hip or knee replacement, and they all were assessed for atrial fibrillation. There were about 500 of them. And something that we found frequently was no diagnosis of hypertension, but they had LVH. And from the LVH, we either traced back that they had hypertension that hadn't been diagnosed, or they had sleep apnea. How about your patients? Do you think there's anything in common here? Do you think this would be a good control group for you?
Thank you. Absolutely. It's a great group to have. I don't think I can tell you exactly if we looked into at least this patient cohort, if there was any undiagnosed comorbidity that could have contributed to higher bleeding on or ischemic risk. What I can tell you is they go through, like any cancer patients, a comprehensive eval. And I'm pretty sure, the sleep apnea will probably be underdiagnosed in a lot of these patients, just like in any general population, and so is the hypertensions. But overall, they're, not a healthy group of patients. Generally, more comorbidities, as with, especially the older cancer, maybe not the younger one, but the older cancer patients are definitely older one and could definitely use a control group for those. A lot of those patients, again, you can see that hypertension was already a diagnosis. I don't know, something I noticed here, I don't know if you've seen this in other places or other cancer centers, that usually these patients are compliant with their, therapy. So if they have a diagnosis of hypertension, they'll come to a clinic on hypertensive, therapies. So typically the risk factors are generally well managed. But yeah, that's a great control group that you have for us. It's like a gold mine.
I'll send you some of my slides, okay?
Sure, absolutely. Thank you.
And Omaima Ali, I think, had a question.
Hi, good morning. Beautiful presentation. Why do you think renal dysfunction was associated with less use of oral anticoagulation?
Yeah. I think the concern here is the creatinine clearance of, I believe, DOACs mostly, which is obviously should not be, and renal clearance, you should just redose your DOACs. But I think, again, I try to put myself in someone else's shoes here, and if you have platelets of 70 and a creatinine of 2, I think there will be concern of the creatinine clearance of the clearance of a DOAC, and perhaps a higher bleeding event. Again, I think it's a theoretical risk. I don't know of any good data to say that you should not do that just because the creatinine clearance is low. I think it's a bunch of factors. Like these patients have, typically they'll have chemotherapy, maybe they have blood before, maybe their platelet is 100, and maybe they have creatinine clearance of 40. And, altogether, kind of pushes you away from having a DOAC. Again, re-education, refer to someone who is comfortable doing that. I think the majority of those patients probably be okay giving them a renally dosed DOAC. That's my thought, and I'm happy to see what other people think about why that could be.
Okay, and I know you've already alluded to that, but knowing this, having more information about the subgroups of cancers, some might be more hypercoagulable than others, correct?
Correct. So obviously those with gastric cancer we know are more risk. Ovarian cancer, for example, more risk of VTE, for example, and thromboembolism on average. On the other side, someone with we clumped all of the hematologic malignancies in one group, but we know some of them bleed more than others. And so MDS patients, for example, are on average have lower platelets than someone, let's say, with diffuse large B-cell lymphoma who got 6 cycles of R-CHOP and now is doing better. But just for the purpose of the analysis, we didn't want to kill the medical students. So we decided to, and correct me if I'm wrong, Dr. Fradley, I think that's mostly of what we did, kind of, did the non-major cancer groups. We thought that would probably constitute the majority of those cancer populations. But you're right. Definitely someone with ovarian and gastric cancer will probably be a higher thromboembolic risk than someone with sarcoma, for example.
Well, thank you so much for this presentation, Dr. Alamar. We're at the hour. Appreciate everybody's comments and questions. Thank you, Dr. Fradley, for joining us this morning. And hopefully you can join us next week for another case review on next Thursday at the same time. Thanks again, Dr. Alamar. Really appreciate your work.
Thank you, Steve. It's a pleasure and honor to talk to you all, and I hope to see you and talk to you in the future. Thank you, everybody, for attending.
Bye for now.
Bye.
Thank you.
Bye. Thank you.